Well, I think there's no doubt about the fact that the COVID era has changed a lot of things. It's affected pretty much every bit of the lung cancer pathway you could possibly imagine. And obviously, me as an oncologist, I look after patients who have been through the whole diagnostic phase, and we've got a diagnosis, we know the distribution of disease, and we've right at the end of that, the decision is about drug treatment to try and prolong life. And that's the little space that I live in. So I see a very little part of the whole picture. And there's a huge amount of stuff that goes on before a patient ever sees someone like myself in terms of, primary care, secondary care, making the diagnosis, the molecular testing. And, COVID has impacted on every tiny little bit of that. I think you can just look at every single little stage. So just for example, the very first thing might be screening. Obviously, screening programs have almost collapsed because of COVID, and they'll restart, but, massive hit there. Just what a normal person does when they start getting symptoms. The huge numbers of patients have been terrified about catching the coronavirus. People have been shielding at home. We've been as a country in lockdown. Many people, they're not patients yet, but many people have been having very worrying symptoms that they have just sat on, really, because they're too scared to go to hospital or see their GP. It's too risky. Their perception is that they could catch something from the hospital. So that's been a huge problem there. Then if you then go into what's been happening in the diagnostic workup, once you suspect something's going on, well, yes, the scanners are still running, but the doctors have been very busy looking after patients on COVID wards. Outpatient clinics have moved to remote clinics. It's not quite the same. It's a completely new set of challenges to managing people remotely and assessing them clinically and deciding what the right thing to do is. Just getting things done has slowed down, because to get a procedure done, obviously you have to have COVID tests to check that you're negative. The whole thing, it's like sludge has entered the system and slowed the whole process down. And the other thing that's really important, I think, is that some of the procedures we do in lung cancer, like EBUS, bronchoscopy, some are aerosol generating. So there's a huge risk to the staff and involved in the diagnostic process. And so at every level, things have been impacted. If we look at my practice as a practicing, jobbing medical oncologist, treating, several hundred lung cancer patients, it's been very varied. I think the most immediate thing that's impacted, and for me, it happened literally overnight, because I had to suddenly self-isolate for 2 weeks, was that overnight I switched from running, I do 6 clinics a week, to running 6 clinics a week from my study in this room, in fact, where I'm sat now. And I would never have thought that was possible. If you told me 4 months ago that would be happening, I would have laughed you out of the room. But the reality is, overnight, all my clinics are online. Video conferencing, suddenly having to adapt to a bunch of different technologies. The NHS has got several different software packages that we can use. They're all slightly different. They all have certain things that are good about them, certain things that are not good about them. Just learning the new way of assessing a patient on a video link, the dynamics of having family members, who's in the room. I can only see the angle of view of that camera. I don't actually know who else is in the room. You don't have a CNS in the room with the patient to hold their hand and support the patient and answer their questions after the consultation's over. There's a whole different way of operating, and we've very rapidly taken that on. And I have to say, I think this is one thing that I'm personally very proud of, and I think many oncologists I speak to, in fact, almost all oncologists I speak to, say exactly what I'm saying, that it's amazing how well we've taken to it. Patients have taken to it, in a very difficult situation. We've got something to work really well. And, you're a cancer patient, you're on chemotherapy. The amount of time it takes to come and see me in my clinic, to get your family together, to come to the hospital, to queue for parking, to get parking, pay for parking, sit in my clinic room, slowly getting more and more anxious about what's going on. My clinics are often overrun to an hour or two. I think that would be very simple. And that's all gone. The patients are consulted in their home. So I think, there's a huge amount of positive learning that the NHS is going to get from this. It's going to change the way we operate. And the way I operate in my MDT meeting, so I'm consulting patients on video conferencing or even telephone sometimes, but multidisciplinary team meetings actually lend themselves very well to online teleconferencing facilities. And all my MDTs, I do sort of 6 hours of MDT a week, all online. Most of them are, in fact, all the MDTs I do are first thing in the morning. And when there's a traffic jam on the motorway, I could be 40 minutes late. It's gone, Everyone's there at the meeting, bang on the set hour, wherever they are. Some are at home, some are in hospital. It's just been fascinating. Images are all presented. Everyone has a good discussion. I think the MDTs have been transformed by video conferencing. I cannot see a situation where we would go back to a face-to-face meeting. I think it's much more effective. That's my personal view. Treatment decisions have had to be altered. There's no doubt about that. Many patients of mine who are on systemic therapy with lung cancer were very scared about coming to the hospital to have chemo and requested time off. And some of the patients are very frail, and they really are on a knife edge. And there are lung cancer patients who are extremely fit and out playing golf and cycling and running, but there's a significant number who are very frail and would not tolerate COVID in any degree well. So a lot of patients had treatment discontinued. And I think one thing the NHS was very good at is also sort of being a bit realistic about treatment options and opening up options that were previously unfunded. And in lung cancer, the two things that really stick out to me is osimertinib was overnight made available first line for EGFR mutation positive patients on the back of the FLORA trial. And it just means that those patients are getting osimertinib. They're less likely to progress because it's got a longer PFS than other drugs. And so they're less likely to need chemotherapy. And then another example is PD-L1, low PD-L1 patients. So PD-L1 expression levels of 1 to 49% currently get chemotherapy or chemotherapy plus immunotherapy. They didn't have the option of immunotherapy as a single agent. And they didn't have that, but there is evidence to say it's fine to do that. I mean, we have a trial called Keynote 42 that very clearly shows that chemotherapy and single agent pembro are equivalent in that PD-L1 stratum, and that's been made available as well. So, organizational funding changes have been made to simplify what we do, and the whole system has sort of rejigged itself to a new world. We're still learning. I think there are things that we will want to go back to. I can't see me having remote consultations as a long-term solution for the rest of my career. It'll be there for certain patients. There's no doubt about it. But what you get from a face-to-face meeting is different. Although I would say I have had some very, very difficult consultations with patients on the video conferencing with my CNS as part of that video conference. And many of them have gone exceedingly well. And both the CNS and I have commented afterwards about how we didn't feel that the fact that the patient was 20 miles away in their house felt that we didn't feel that that actually was an issue. Another very nice anecdote I have is I saw a new patient some weeks ago whose entire family live in New Zealand and she lives here alone. And I'm having a consultation with this patient, me and the CNS. It's a difficult lung cancer consultation. The family are on the other side of the world, and they were texting her at the same time as the conversation, and she just mentioned that in the consultation. And I sort of said, well, do you want them to join in this consultation? She said yes. Within 2 minutes, the family were all there from the other side of the world. And we had this most amazing new patient consultation where a lot of stuff got discussed that needed to be discussed, but the whole family were part of it. Now, I thought that was wonderful.